Mobeen Sayyed from drbeen.com. Welcome to one more show. So, Carolyn, hello. You are the first one. DDS, hello. How are you? Sumit, hello. Christy, hello. Doug, hello. Dishri, hello. And Frankie, and I'm sure that more people would join soon. So, thank you very much for everyone. Simple Garden is here. Violet is here. Margaret is here. So, welcome everyone. So, once again, I'm sorry if this setup has any issues. I know that if I put my hand on the table, it would shake the camera. So my apologies for that. I hope these sounds on the roadside are not too disturbing. But if this is, then please tell me. I like the background. Yes, she has a good taste in the general setup of the house. She has two cats as well. And when I arrived yesterday, cats were all over the things that I brought with me, and so they had to inspect everything. So I was taking their pictures and sending them to my wife, and she was saying, "It looks like you have received a warm welcome." So so till today, the cats. One of the cats, she's sitting right here. She today actually leapt up all the way here and just sat there and was just smelling me. Luffy and Kyrie don't do that. They are a little different. Oh yes, 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 yes. So Michael says, "Who is the handsome young fellow? Nice haircut." So somebody was talking about my hair, and so my wife decided to cut my hair. So this is my wife's doing. Jim is here from Iowa. Hey Jim, welcome. Jim, I hope you're doing well. Anna says, "Where are you?" So this is North Bend, Oregon. So I believe it's a 10,000 people city. And how I know this is I told Margaret, the cool bean Margaret, that I am in North Bend, and she did some look up and she said, "Okay, this is a 10,000 people city." So small city, small town. And my friend, who is a colleague, she's a part of team of Dr. Bean. She's also a PhD in nurse practitioning, and she practices here too. Azraelina Rakoczy says, Dr. Movie says you look handsome. So thank you very much. See how shy and hesitant I became. Loretta says, thank you. All right. So tell me, what are the good questions for today? Yes. So Patty says, Luffy will going to have to mew a lot louder. Yes. Luffy is now 10 hours away from here. Ditching the grind says, haircut looks good. Thank you. Loretta says, why are you not at home? So Loretta, one of our colleagues, my team members at Dr. Bean, she developed some, of course, I don't want to discuss her medical condition, but about a month ago, she developed a medical condition that caused her to develop seizures, and then the condition became further destabilized when her doctor did not manage her well, and quite a story. The result was she ended up in a hospital, coded 3 times, and finally, now a few days ago, she came back. And her, of course, this was all such an urgent and emergent thing that her family members were not here, so she was with someone. So she asked me that, hey, if you could help me get back on my feet health-wise. So here I am. It's a doctor's call. L says, setup is fine, and I think you got a haircut. Yes, looking sharp. Thank you. Simple Garden says, yeah. So while my colleague was not here, she was at somebody's home who were tending her. The cats were alone at home. So yeah, they were quite, they were quite inquisitive yesterday. Every single thing I opened, my things to wear, my toiletries, my clothes, my books, my cameras, these things, they had to inspect every single thing. Correct. So Eileen says, hope she has a complete recovery. You're a great friend. Thank you very much. Yes. So when I picked her up, she was she was just not in the best of her shape. But today, just one day's attention, she was actually just walking around a few minutes ago. So good to know that she's recovering. Mr. J says, question, what is the right test for antibodies? IgG specific, IgG plus, IgM combined, and why? So very good question. I've discussed this a few times in the past. So let's do that, a quick review. So I'm going to. So for the SARS-CoV-2, this is specific for SARS-CoV-2. For SARS-CoV-2, if I can share my screen. So for SARS-CoV-2, what happens is that, let's say we get infected somewhere over here, day 0. Our adaptive arm would take a few days to become activated. When it becomes active, the very first set of antibodies it would create is IgM. So first note, the antibody test is not great to see an acute infection because acute infection may be going on without yet the antibodies produced. So because of that, during the acute infection, an RT-PCR is preferred. Although doing an RT-PCR plus an antibody test will also tell you if the patient is in this kind of a stage where they have passed through the initial time of adaptive arm getting triggered, and now they are in a state where the virus is still present, but the immune system is also ramped up to the adaptive arm. In another few days, the virus will be eliminated in most people. So IgM will go up. In SARS-CoV-2, IgG goes up at the same time. So IgG, what a perfect line I drew, just on top of the other line. So IgG will go up at the same time. In other infections, IgG actually goes up later. But here in SARS-CoV-2's case, both of them go up together. Then IgG would continue to stay up for 2 to 3 months. We know that part, correct? So 2 to 3 months. Then it would start declining. It would go down to a baseline, not become 0, but a baseline. And we know this as well. So tell me, cool beans, what is the reason for this, and then for this? So can you tell me, A is responsible? What causes A? What causes B? What causes C? Today is your test. When we study together, we should have tests as well. The IgM, on the other hand, so while you're thinking about A, B, and C, IgM, on the other hand, would go down soon and be 0. This is the basic graph of the antibodies. So now if we go back to the question from Mr. J, that what should we test? If you're trying to figure out, am I in active disease? Then RT-PCR plus maybe IgM, because IgM is a more temporary antibody, it would go up and go down in a shorter period of time. So if IgM is present, that means infection is more acute. Infection is occurring right now because the first responder, antibody is present. On the other hand, if you test for IgG, then IgG would tell you if it is present. And then depending upon what is the titer of this, A, B, or C, it would tell you if you have the disease and the immune system has worked on it, or if you had the disease and immune system is now just sitting at a basal level and waiting for the reinfection to occur. Then sometimes it is possible that the antibody titers are really low and they are of not good significance, and you can do a T cell to also know if I had the infection in the past. So now just very quickly, let's see if somebody responded to what causes A, B, and C. Okay, so nobody responded. Come on, cool beans. This is why you're a cool bean, that you would respond to this. Okay, so let me very quickly explain this. A This is active infection, and IgG means that the plasma B cells are actively fighting against the infection by releasing antibodies. And this could be here, and then they would continue to make antibodies for some time, even if the infection is not there. So you did RT-PCR and that is negative, but IgG is present. That means body looked at the virus, eliminated it, and now is still continuing to just provide protection for some more time. And body is wise in doing that. And the reason for that is, if you got infection today, then it is possible that you're in an area of pandemic according to the body, and you might continue to get reinfected. So it is just going to continue to send antibodies to keep you protected for some more time. Then about 2-3 months later, the B would occur, that is the reduction in the antibody. That is because the active cells would finally say, you know what, it doesn't look like this person is going to be infected again, so we are just going to die and not create antibodies forever. If during this time a person does become reinfected, then they would start making antibodies again from here. But if they don't, then they go down and they would start making basal level. This basal level antibody production is a sign that memory B cells in the bone marrow have been produced and a longer lasting immunity has been developed. If this level is low because these cells would slowly continue to going to rest, then, and you still want to know if I had the infection or not, then a T cell can tell you, because we can detect the memory T cells. So this is the, I hope this explains it, Mr. J. Let's see. Doug, you are absolutely correct. C is the memory B cells, very correct. B is the viral. Virus has already cleared, but immune system cells think that virus has cleared, we don't need to work anymore. So very correct. That is B. And of course, I'm sure that you would have said A is active infection or being eliminated. Okay, so now let's look at more questions. Daniel AO says, getting immune booster as well as immunosuppression within a short period of time. Booster and suppression time disrupt our whole, are you going to say whole immune balance? Depends. There is no immune booster. There are immune optimizers, which would balance out the function of the immune system. The concept of immune booster is more of a marketing thing. Marketers wanted you to say, oh, this would boost my immune system, I want to have it. Boosting is a term better used with vaccines or reinfections to say every time a vaccine needs to augment your immune system, a booster of the vaccine may be needed. So it's a booster of the vaccine, not booster of the immune system, which would in turn boost the immune system. Similarly, you could be reinfected by natural infection, and that would boost the immune system as well. But saying that you can take a medicine and that would just boost the immune system, that I would say it optimizes it, unless that medicine that you've taken is a vaccine or is a probiotic or is some sort of a pathogen that causes the body to produce, then that is immune booster. But vitamin D's, C's, and those, they're not boosters, they're optimizers. So now when you take these, you would say immune optimizer. Now with that, if you're taking immunosuppressant, that is fine. What you're doing is the following. You're saying, I want my immune system to be balanced in its function, but I do not want my immune system to be overactive either. So being balanced is different from being overactive. Being balanced means behaving correctly, meaning the T cells and B cells and everything is orchestrated correctly. Being overactive means that it may still be working correctly, but working too much. So when you are saying suppression, are you bringing it back to the normal level, or are you bringing it below the normal level, for example, in the patients of transplant or chemotherapy and so on? So again, I do not have your complete question, but I added whatever I could. Peter Positive says, my daughter recovering. Good, thank you. Congratulations. Ivermectin saved her life. Bad diagnosis led to pneumonia and low oxygen. Second doctor issued steroids and good meds. Now what dose of ivermectin in recovery phase? So usually for my patients, I continue to give them one full dose of ivermectin. Full dose is calculated by the patient's body weight. So let's say 0.15 milligram per kilogram body weight, or 0.2 milligram per kilogram body weight, or in a in a place of hotspot 0.3 to 0.4 milligram per kilogram body weight. So that is one full dose, and I continue to give that till the patient recovers daily. So I don't say 3 days or 2 days or 5 days or 1 day and 2 days. I just continue till they come out of it. If it is a COVID long haul state, then 1 week or 3 or 4 days of ivermectin continuously, then weekly, and so on. So there are various states, but this is the normal approach. John Ria says, if the world were to be categorized into 4 groups, vexed only, ivermectin only, vexed and ivermectin, nothing, is there one group that is more likely to create more destructive variants when infected? So, John, no. So we cannot say any group, may that be not vaccinated or vaccinated or with ivermectin or without ivermectin, as you've said. The production of a variant is not dependent upon the intervention. This actually, for example, anti-vaxxer, I don't want to say anti-vaxxers. Some people said to me that, hey, you say anti-vaxxer and that is derogatory. Fine. So those who do not want anti-vaccine, or who do not want a vaccine, they say somehow the vaccinated people are going to cause more variants. Those who are vaccinated are saying, hey, those who are not vaccinated are going to cause variants. So basically, everybody who's infected can create a variant. Variant is going to be lethal or less lethal is going to be a random act. Just like when we are born, we have specific shape, features. You cannot look at just parents and say, I know exactly how the new one would be. You can predict which hair color and skin color and those things, but still you cannot say what would be the features. That is the same thing when the virus daughters are produced. We can't say what these are, and these interventions are not going to affect the lethality of the daughter. They're actually, these interventions, as much as they can cause I know where people are going to comment now and say, well, immune escape can occur. So here's the deal. If immune escape can occur, that is a random selection act. Similarly, the unescape can also occur. Destruction can also occur by a random selection act. Why don't we talk about that too? So no single intervention is going to cause a more lethal system. So Daniel, we just answered that. Oh, did I show you my painting? Let me show you my painting. So this is the painting I did over this weekend. The painting was, as much as we are present for the folks around us who are suffering, still there are some folks during this pandemic who lost their loved ones. I think we all know now people who have lost their loved ones. There are people who are suffering through long hauling. There are people who are suffering through chronic diseases now. And as much as we would all be here, we would all be supporting, we would all be loving and caring. I'm here, I'm caring for a person. Still, the person who's going through it, it is their pain to bear and then manage and to handle. So this was for after the pandemic, some of us who have lost their loved ones, they are going to have a journey without them. So with this, let's see more questions. So RDH says, Dr. Bean, Dr. DeMello, during your interview with him, briefly stated he used colchicine as prophylactic. Any idea on dosing? Thanks. So he talked about the dosing as well. I do not know exactly what dose did he use. We can ask him, but you can take therapeutic doses and that should be fine. And to see the therapeutic dose, just Google therapeutic dose of colchicine. So Aditya says, would you recommend a person to keep taking ivermectin even after recovery as a prophylaxis? weekly or 15 days. So once again, I would tell you what I do. So when I came here for my colleague, I had to travel. I knew that on the way I'm going to be stopping to use the restroom or to get something to eat or drink water or fill the gas. Then over here, when I will be taking care of her, probably I'll go out, get food. And so I'll interact with people more than I used to when I was at home. So I took ivermectin, and I am vaccinated. And it is funny that somebody had put a comment that I'm paraphrasing, that they said to me was, you look like an anti-vaxxer by taking the vaccine and still taking the ivermectin to give an impression of the vaccine not being effective. And I cannot imagine people can come up with a objection to everything. Anyways, my own preferences, that I know that vaccines are effective, but not 100%. I know ivermectin is effective, but not 100%. I know, social distancing, hygiene, mask, they're all effective, but not 100%. So I try to do as much as I can. So even after vaccination, I'm taking ivermectin. So similarly, even after infection, you can decide to take ivermectin. It is your call. Generally, these infections are 95% efficacious as well in preventing the next infection, or not preventing, but creating asymptomatic reinfection. So Jill says, negative antibody test, 3.5 months illness. What does it indicate? If a person has clinical symptoms of COVID, expert pulmonologist diagnose clinically negative PCR, early treatment ivermectin plus hydroxy plus azithro plus supplements. At 30 days, 95% better. Then 2 days later, recurrence more acutely. Bartonella that was in remission, years reactivated. Only intermittent ivermectin plus hydroxy, trouble accessing at 3.5 months, still respiratory symptoms. Never lost sense of smell, but many other symptoms. So my request for the doctor will be to start so again, this is not an advice for you or for anyone. In theory, if I am the doctor of a patient who's going through this, I would stop everything else and I would start them with budesonide, and I will give them systemic steroid pulse. So I'll probably give them for 15 days or for a whole month low dose therapy of steroids, and then I'll taper it off. Then I'll see what the symptoms are, and then combine steroids with ivermectin, and then go from there. Lizzie says, love the painting. Thank you very much. Abdullah Musa says, did you see the latest study from Germany on mixing the vaccines? It shows better immunity and not more side effects. And they think UK studies seem more side effects because the 2 doses was after 3 weeks. I have not seen it, but I would check it out. And it is actually, I understand this, that this is entirely possible. Kelly says that painting was gorgeous. Thank you very much. Correct, Alfred, that sounds like a long haul, correct. Tika says, Dr. Mean, do not listen to the annoying people. Thank you for not being biased about this issue. You're very welcome, and I'm not. So one thing that folks who put these comments do not realize is I might sound decent and polite, but I am very firm in my ways and in my understanding of things and then working on them. If you want to change my opinion, then that opinion will certainly not change if you start cursing me. That would actually, I'll just shut you out. And if you would just say, well, I think it is this way, or you are doing this way, that would also not help. The best way to change my opinion is to work with me with data, to say, hey, let's look at the mechanisms and data. And when somebody sends me, Geert said this, and I say, where is the mechanism? And there is no mechanism, then I can't do anything. The mechanisms have to be there. A Simple Garden says, Dr. Bean, your paintings appear to be a therapeutic journey for yourself as well. Yes, yes, because I go through. So, Simple Garden, a friend of mine said to me, as you might have seen, I become very upset when my patients do not recover fully, or they have a loss. For example, my brother's mother, my class fellow's mother, who I was managing, when she passed away, I was very, very disturbed, and I painted and I mourned her. To which somebody said, your feelings are not important. Just go and console with them, and you are a doctor. This is your job. Somebody else said to me, you are not a professional to feel this way. I actually think it is professionalism. My profession is to take care of my patient to the point that I can try to recover them 100%. And if I fail in there, I should feel an emotion of failure to learn where could I have done better, than to try to become better. But if this is professionalism, to say I don't feel anything, this person, well, some people die too, then I will not do better as a doctor. I would do that run of the mill medicine, that actually I'm here for a person almost dying because of the run of the mill professional medicine. So I am generally very proud of these things, the way I work. Luis Grande says, is neural damage and or bulb atrophy able to regenerate? Fortunately, there are about 10 million receptors in the olfactory bulb. So if 100,000 or 10,000 or 5,000 are damaged, we don't care much. However, if there is a disastrous effect, then no, they cannot regenerate. But most of the time, we have not seen that kind of an effect. And back to the Simple Gardens, yes, it is a therapeutic journey for myself as well. Martin says, I used anti-inflammatory drugs after 5 days of my second dose. I'm worried, can that affect the vaccine and immune system response, even though it was after 5 days? Not at all. Even if you were taking it that day or taking it a day before, it would not. And I'll give you an example of this. When sometimes we get an infection and we have fever and we start taking antipyretics, does taking an antipyretic immediately finish the infection or exaggerate the infection? Finishing the infection would mean immune system is too much boosted and it just goes and clears out everything. No. Does it exaggerate the infection? Does it cause that you took an anti-inflammatory and now the infection is going on forever? Anti-inflammatories are not immunosuppressants. Even when you're taking steroids, even then our body can take care of things unless you have totally 100% immunosuppressed the person. So anti-inflammatory mostly of the counter are nothing. William Goff says, just an FYI, I've been advocating for 300-pound, 55 plus diabetic on a vent. Convinced doctor to give 0.4 milligram per kilogram of ivermectin plus Prozac because he refused fluvoxamine. And 3 days of it, she's coming off vent. Congratulations. Love it. Thank you. So, Jamili, I'm sorry, I'm shifting on this chair as well. These are actually wooden dinner table chairs, and I'm sitting on it since the whole day for preparing the lecture and now doing it. And I'll put something on these chairs. So, hi, Dr. Bean. Delta variant in UK leads to more new cases. Does vaccine work? A lot of people are vaccinated in UK. So first, I saw this over the weekend. People are having a ball. Media is having a ball with this. So I'm going to show, this is a very important question. Let me actually show some data to bring us all on the same page. I'm going to take these out. So let's say if we go to Worldometer and we look at UK. And let's look at this. This. So if you see, UK had dropped down to 2,000 cases. If I do a 7 days average, at some point they were at 2,000 and now even lesser, and now they are at 4,000, 5,000. So if you do a percentage on it, you would say that it has doubled. The number of cases have doubled. And similarly, when you compare that to here, look, when we were 2000 here, let's say that was September 8th, we went to 60,000 per day by January 9. So September, October, November, December, January, 5 months. Within the time frame from September to November, September, October, November, 3 months, not even 3 months, 2 months, it went up from 2,000 to 22,000. So now the question is this what is going to happen again? And that is what media and people were just making lots of noise about. You can actually see that the ramp, the growth is not very similar to this, number one. Number two, this is incorrect to say a lot of people are vaccinated in UK. UK, I believe, 2-dose vaccination is about 60 to 70%. One dose is 60 to 70%. 2 doses 30%, if I am correct. That means, and I have been drawing these things in the past as well. Let me just get the numbers correct and I'll draw. So here UK, 1 dose 60%, 2 doses 41%. Now let me explain how should we look at it. What should we expect? So this is a correct position to say, hey, Delta variant or the 6172 or the a variant originated from India is faster, even more faster. So that means it would spread faster, it would cause infection faster. Do you know that the death rate is not actually increased? This goes with my theorem, not theorem, it is a epidemiological and immunological thing, that when a pathogen becomes more efficient in spread, it becomes less lethal. And here the deaths have not kept up. And to the dismay of some of these writers, they said, well, let's wait. This would happen as well. I would say, why not be a little more positive to say, maybe this is less lethal. But anyways, their death rate is not catching up. And this is fair to say, let's wait for two weeks, because death can occur from 2 to 6 weeks. So agreed with that. Now, let me explain what are the possibilities. Look, people who are vaccinated, let's take the 30%, 40% that are fully vaccinated. We know that there is a percentage of them that will become reinfected. And a large percentage of them can become reinfected. We can all become reinfected. Reinfected simply means the virus coming back in our body once more. The question is, can our body now handle the virus better? That is the point of vaccine or a previous infection. So reinfected, I would say, with symptoms and possibly even a chance of death. So we are seeing so far that in the previously infected or with previous vaccinated, this is really slim. This reinfection which has been detected is also tiny. So can reinfection happen? Yes. Would it be too bad? No. This is one group, 40%. Now the remaining 60%, let's say out of them, there are some that had actually already gotten infected and recovered. So what are that number? 4.5 million. So now if you go back here, I think UK's population is what, 55 million? If I may be wrong. So let's say there is another 10% that is infected and recovered. They have the same possibility of reinfection as vaccine-related reinfection. that they can actually get Delta. They might even get some symptoms. Majority of them, like the study I did with Qatar, that 67% of them would not even know. You would find a reinfection in them if you continue to test them on daily basis. And that is fine. And I've said it many times, a previous infection or a vaccine does not tell the virus to not approach this person anymore or to not land in their mouth anymore. It also does not stop the virus from replicating in that person for at least a day, because there would be 24 to 48 hours for the immune system to get up and respond and kill that virus. During that time, the person would have even possibly symptoms. Then, so let's say this is 50. Then there is another 20% that is weakly, they're weak. They have one vaccine dose done, but not fully. So there is a possibility, a lesser possibility, but a possibility of infection. And then there are those who are asymptomatically infected and recovered and have never been acknowledged that they have been infected and recovered, and we do not know what their percentage is. Can they also become reinfected? Yes. And then there is a group that has never ever encountered the virus. They have never ever had a vaccine, and they are open as well. This is open. There is part of this open. There is part of this open, part of this open, part of this open. This whole thing this whole segment of population can get the infection. So if you put in this population anywhere, UK, US, wherever, a more efficient pathogen, it will create more cases. So in my opinion, I don't think that there is a cause of concern to say the new variant Delta is going to demolish once again like this the UK's current status. I don't think so. But neither has anybody else seen the future, nor have I. So my prediction is just as good as somebody else's prediction. The only thing is my prediction is more calming and saying, hey, don't worry. Other people's predictions over the weekend, I saw that, all right, we are dead. And it is also interesting that when somebody says, if I said right now, I did a video and said, people in UK, you are in trouble. This is Delta. It has come in your land now. And everybody who's vaccinated is at risk. Everybody who's infected is at risk. Everybody who's never been, they are at risk. And now the children are going to be at risk and adults are going to be at risk. And you guys just are in trouble. Believe me, that video would be watched millions of times immediately. So I think that we should look at things in a more objective way. Okay, so good question. I hope this answers that. Fruendisis says, how is it possible that someone with COVID has low D dimers and very high platelet levels? Someone with COVID has low D dimers and very high platelet. That may be a different kind of a pathology. Maybe it's not COVID's doing. Maybe they had that. So the question is, what was this person's history? So Danielle says, how do we manage severe COVID patient who has hemophilia? Can his condition clear those thrombus or emboli without blood thinners? It really depends upon the D dimers and ferritins and CRP levels to see, is it helping or not? If it is not helping, then add blood thinners or add blood. So it really depends upon the labs, and then the decision would come together. So Paul, Doug says, what is Delta? So it is actually funny for me that when the virus started from China and we started calling it Wuhan, and China objected and WHO ran and said, okay, don't call it Wuhan, call it, what was that, SARS-CoV-2. Then there was a variant in UK and people started calling it Kent variant or UK variant, and nobody really objected too much. Some people would say here and there, we shouldn't call it that, and we should call it B117. But there was no WHO coming in and saying, oh, this is totally wrong. It is a funny thing to me to observe from WHO. Then came the South African variant. We still call it South African 135. And once again, There was a lot of hoopla. You can just Google and see the news that South African variant is deadly and more efficient and all that. But nobody from WHO came up and said, no, 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 don't do it. Don't call it South African. Call it 135. Then Manaus, P1 Manaus, then California, then New York, and so on. And here comes one more variant from India. And people started calling it Indian variant. And all of a sudden, once again, folks from India objected and said, don't call it Indian variant. It is a variant originated in India. And call it 617. And WHO rushes and says, no, 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 let's just name them all differently. And let's call them every variant, some variant alpha and then beta and gamma and delta. So delta is 6172 that is originated from India. I think it is kind of, anyways, that is WHO for us. They have nothing else to do. Bhargavin 123 says, is there any evidence that glycine supplementation works on prophylaxis? I have no idea. I've not read this. There may be, but I do not know. David says, question, can a vaccinated person pass the virus to a non-vaccinated people? So, David, short answer, yes. And vice versa as well. Can a non-vaccinated person pass the virus to a vaccinated person? Yes. This is a wrong way to look at things. And since the vaccinations continued and people like Geert came in and Tenpenny came in and Dolores came in, and they tried to say, stop the vaccines, and the vaccine didn't stop. Then this new thing started that people who are vaccinated are going to make the people who are not vaccinated sick. That's just bizarre. People who are not vaccinated can make other non-vaccinated sick as well. So then it became they shed spikes, which is also incorrect. Then it became that vaccinated people will be more asymptomatic and then they'll be giving the virus to other. Well, guys, anybody who's moving outside and giving the virus to others didn't feel enough symptoms, and that is how the virus has been going around. It was not the vaccinated people from the first go. So it's just strange. But anyways, this question, short answer, yes, and the vice versa, yes as well. But long answer, this is not even a good question to ask. That was also not a long answer, right? That was also a short answer. Danny Ball says, how can I get ivermectin in Canada? Oh, Danny, this is the most common. Even if I open up my phone right now, the most number of messages left by people are, how do I get ivermectin in Canada? I thought the best way is to get it online. What I do not know is if Canada allows the drugs to come in from India, for example. What is this? WT says, mask till I die. WT, are you being sarcastic, or do you feel that mask would kill? Mask will not kill. Okay, so let's see more questions. Wayne, how are you? So Wayne, about you, so I think a couple of days ago, somebody asked a question that totally startled me. Gold Country throws out some philosophy. Only dead people can't be infected. Anyone else for sure. Yes, correct. Fuckum says, have you talked a lot about ivermectin? Have you looked into Luvox? I have not, but would you then just pronounce your name again? So Sawan Gan Kid says, do Chinese vaccines induce mucosal immunity? So once again, this is another question that in itself is not the best question, but I would answer this one. So let's look at this. When an infection occurs, that could be by the actual infection, That could be a vaccine. An antigenic or immunogenic event occurs. Our immune system trains or prepares our adaptive system. The innate arm says to the adaptive arm that, hey, get ready. So we can go T helper 2 pathway, and from there we can go to B cells making plasma cells, which will make antibodies, usually IgM. And then we can also go T helper 1, which will make cytotoxic T cell. And it is possible that both of those mechanisms are engaged together with some percentages. However, to answer your question, look, our body does not know that we are in a pandemic or we had enormous streptococcal infection or staphylococcus or EBV or hepatitis. It just knows how to work. So IgM is produced as a first response. Then some cells will become separated and they would do class switching. Some clones of this will do a class switch and make IgG. Then some clones of this will class switch and make IgE. And then some clones of this would class switch and make IgA. This is a normal behavior of our immune system. The only question could be, what is the percentage of these creations? What is the percentage of class switching? So it depends upon how a specific antigen encountered us. If the antigen was more from a respiratory pathway, then our body would have B cells that can do quick class switch to IgA and produce that. If it is through a muscular system, which is any vaccine, then that may be less IgA compared to more IgG. But IgA would be produced as well. So now to answer your question, do Chinese vaccines induce mucosal immunity? I would respond to this by saying the question should be, should do any vaccine given in muscle produce mucosal immunity as well? And the answer will be yes. It may not be as strong, but yes. I know that a follow-up question then would be, would the people start shedding? Well, that's a different mechanism. I've discussed that in detail in a separate discussion. Hey, cat. So this cat is just playing around. And she has a very, very small voice. I was surprised to hear these both cats' voice. They're like, me, compared to Luffy, who's like, wow, Luffy is something. Okay. So Daniel Ao says, is cytokine storm phenomena occurring due to faulty gene or restricted on some certain person with genetic defect? I see lots of more cases of CS these days. If we knew, we would have stopped it. Just like some people develop allergies and we have no idea why. 80% of the population is fine with certain allergens and 20% responds negatively. It is genetic in nature. But what gene and why, we do not know. Similarly, SARS-CoV-2's behavior is anchored in genetics and the body's composition. For example, vitamin D levels and vitamin C levels and the general health and diabetes and so on. But the cytokine storm's underlying is a genetic predisposition as well. Doug says, hi, Kitty. So she is so funny. What she did was she was playing with a tiny ball. And so she pushed it here and came and played here. That was her way of telling me that I want to play with you. And then I kept talking and she took that ball there and now she's playing there by herself. Lizzie says, possible that vitamin D level. Absolutely correct. Control of blood sugar is very important. Vitamin D levels are very important and so on. Obesity or reduced obesity. Obesity is an important factor as well. So these factors definitely have an effect. What is the underlying mechanism is still not known. Jerry says, best test to determine level of antibodies, T cell virus protection. What do I ask for? How? So for the antibody, it's very simple. Just go anywhere and say, I need an antibody test. And for the T cell, I think it is called T-spot. So you can just Google. There is only one test that is approved. So either go to FDA's site and look at the test of the approved authorized tests, or just Google it. T-spot, I think, is the name. M. Gregory says, are males prone to myocarditis from vaccine? So males and females both. Males more. But in Israel, those 62 youngsters, they were a mixture of men and women. And then the people who died too, one was a male and one was a female. L says Luffy is a screaming demon, but in a very cute, lovable way. Yeah, L, when he stands next to my wife and does that howling, he makes her sick. M. Gregory says, I miss Luffy. Yes, me too. After looking at these totally polite little decent cats, which don't even raise their voice, they just I see that Luffy is just too much. He's a spoiled brat. Lynn Petty says, is it possible for long haulers to be misdiagnosed as Huntington's, resistant to idea? Huntington's. Why Huntington only? So I think if you're gonna misdiagnose a long hauler may be misdiagnosed for many other possibilities. For example, brain fog and concentration issues are being misdiagnosed as psychological issues. Similarly, tiredness, fatigue, muscular skeletal issues are being misdiagnosed as fibromyalgias. Similarly, GIT issues are being misdiagnosed as GIT, what is that? IBS and those. So misdiagnosis can be. Huntington is a very specific disease in which the person with the genetic structure would finally start having tremors and unable to move correctly. I do not know what made you think about Huntington. Do you know some long haulers who have tremors or? Okay, so this is important. One says that people from Canada can buy ivermectin online from Mexico. It is sold without prescription. Yes, because so many people have been asking. I actually have to respond to some phone voice messages for this as well. Frisco says 200 kids under 15, 100 are vaccinated, the other 100 all COVID. Which group is more likely to have higher myocarditis rates? Frisco, this is a good question. I have not done this data analysis. So without analysis, I don't want to talk just to say something. This is a good question. It is making me think as well. So I'll have to look it up. Pandora says, or Pandora, in UK there is post-vaccine antibody test, which shows IgG, IgM, and something else I can't remember. Please, Dr. Bean, what is that? I have no idea. IgG, IgM, and something else. This is interesting. Wayne says, get a travel ticket, get the ivermectin, cancel the ticket. Man, our society has come to this, that people just getting a safe ivermectin drug, they have to do all this. Somewhere in history, this will be written how badly our healthcare authorities approached their own citizens. Cyproheptadine is a serotonin against which I understand, agonist, which I understand. But normally serotonin is removed by breathing, but can't in COVID. So how does cyproheptadine rid the body of serotonin? Urine, feces. So I believe that what it does is cyproheptadine, that it is a receptor blocker. So it does not remove serotonin. It just does not let it work on the receptors. UMGS tube. Any advice on ivermectin dose for dialysis patients, prophylactic and active treatment? So dialysis patients, if they are on dialysis because of the renal failure, then ivermectin has nothing to do with the renal process. Ivermectin is primarily metabolized in the liver. So if the liver is functioning correctly, then they don't need to adjust the dose. But if the liver is also not functioning correctly, or they're taking drugs that are, for example, blood thinners or drugs that are working on the PC cytochrome 450 system, then they would need to adjust it. Their hospital or online drugs.com can help with the drug interaction. But generally for renal, not much dose change. Again, not a specific advice for a patient, just an educational piece. So Sandy says, only 10% of vax deaths and harm being reported. Too much at 10% side effect of messenger RNA shedding is not being reported, causing harm for 3 weeks. So Sandy, question for you, how do you know? When you say 10% of vax death, do you know what it is? And what is your data point? Baljit Singh says, is there any latest positive data research on AstraZeneca? I haven't looked at the latest. So totally me. Good. Says, why is it said that a COVID positive asymptomatic vaccinated person will not spread the virus as much as a COVID positive asymptomatic non-vaccinated person? What is the mechanism? Why is it said that a COVID positive asymptomatic vaccinated person will not spread or will spread the virus as much as will not spread the virus as much as I see? Okay, so that I can explain. And there has been a study as well that showed that this is true. So your question is, here is a person. I'm making the person intentionally a little bigger because I'm going to use his mouth area. And here's another person. So this person and this person. So this is a vaccinated person and they got COVID. Now they have IgA in their mucosal membranes. So because of that, they would still shed, because for about a day or so, when their immune system is waking up, they are going to be infected and the virus would replicate and would be shed out. So at that time, the amount of shedding would really depend upon how much IgA is present. IgA's presence would start declining after a few months. So it really depends that what is the time since the vaccine. So if it is a time, let's say 3 years away, then they would shed just like any other person, because the immune system is going to wake up after 1 or 2 days. Until that time, they'll continue to shed. After 1 to 2 days, their shedding would go down drastically because the immune system would wake up. It would start making antibodies, including IgAs. IgAs would take the virus that is in the mucosal membranes and block it. So this is the vaccinated asymptomatic COVID positive patient. Now let's look at the naturally infected non-vaccinated. So same thing, but non. So this is a naturally infected COVID positive asymptomatic person. It looks like his beard. So here. So once again, the question to answer will be, what is their IgA levels? IgA level. In my opinion, this is an opinion, I don't have data to prove it. In my opinion, a naturally infected person's IgA levels should be more than a vaccinated person's IgA levels, because the virus arrived in a naturally infected person through the respiratory system. And so the cells in the respiratory areas or mucosal surfaces will become triggered and they would do more class switching towards IgA. So better protection, in my opinion, for the naturally infected on the mucosal side. However, this would also then depend upon the window of time that is spent. 3 years later, they may have a similar behavior as that of a vaccinated. 3 months later, their behaviors will be similar, but also I think IgA would continue to be more in this person. So that is how to look at this. I don't think that there is enough to say this would be very different one way or the other. But in my opinion, naturally infected persons' IgA levels should be better than vaccinated persons, but there is no data. So I may be wrong. Or when I say there's no data, I do not know the data. Maybe there is data. So Jody says, I think they don't really have good science to back that theory about vax asymptomatic. Correct. The reason for that is, let's say you have vaccinated 100 million people. How do you now know they're shedding or not? How do you know which were asymptomatically infected or not? So the only way to do this is to just continue to study them, just like Qatar did. And Qatar studied 50,000 people, and they kept taking their test every week, or whatever their frequency was. And they came back and they said, well, out of the vaccinated people, 67% were asymptomatically infected. So now, were they shedding as well? To prove the shedding for both vaccinated or infected or uninfected, it is a difficult thing to say this person is throwing the virus out. How do you measure that? How do you see how many people they got? So you do contact tracing and so on. So it is kind of a difficult thing to work with. So yes, you're correct, Jody. Carlos says, if a hypothetical 32-year-old male with mild hypertension, controlled and good vitamin D levels decide to wait for Novavax, how safe would it be with ivermectin plus fluvoxamine if he ends up getting COVID? So I'll give you my own example that I did not wait for Novavax. I loved Novavax. But as soon as my turn came up for some vaccine, I took it. The reason was, as much as from a data point of view, I can prove that there will be between 74% to 99% efficacy. But what if I ended up in the 26% and ended up with a full-blown infection and even dying? Again, there is no guarantee that I would not die now. But I think it is a job. It is reasonable for a human being to try to protect themselves as much as they can. So this is my answer to this question. Otherwise, I would have waited for Novavax as well. Doug is always so funny. So Doug has those single one sentence, one-liners. So exhale on Petri dish. Yes, but do you give the Petri dish to 150 million people? Mr. J, how could the virus escape vaccine immunity? What has to happen? Very simple. It's actually very, very simple. The simplest thing is vaccine immunity or infection immunity. What you're saying is virus becomes brand new. So for SARS-CoV-1 versus SARS-CoV-2, that is a difference. Although it is not SARS-CoV-1 that became SARS-CoV-2, if SARS-CoV-1 became SARS-CoV-2 with 16% genetic change and phenotypical change, that means structural change, then we have a escape. So if SARS-CoV-2 right now has fractional changes, fraction of a fraction change, 0.001% change in it. But imagine it develops 10% change, 15% change. It is wholesale change in its behavior. Then we have an escape. To produce that escape, we have to work for about 100 years for the rate it is changing. CP Joshi says, is not hydroxy plus zinc a better prophylaxis than ivermectin, as hydroxy half-life is 40 days, while ivermectin is 18 hours, keeping hydroxy side effects on the side? So if you just want to measure it based on the number of days, even for ivermectin, remember the studies that came out, they had given 1 day, third day, and then the whole month, nothing. And they worked as well. So there is a tissue distribution or fat storage of ivermectin as well that goes on for a long time. But if you just wanted to measure on this narrow band of storage and availability in the tissue, then yeah, hydroxy is better. It has more half-life. On the other hand, if you compare them holistically, my comfort level is more with ivermectin, although I've used hydroxy a lot. just because of the lesser side effects. The compliance is another band on which you can compare them, and compliance is difficult. With hydroxy, you may have better compliance because you give it with lesser frequency. Ivermectin may need more. So all of those have to be looked at together. Dr. Tariq says, question, what affects COVID-19 vaccines for patients? What's affect COVID-19 vaccines for patients with hematological conditions? So Dr. Tariq, am I getting your question correctly that you're saying patient with hematological conditions, does vaccine have a bad effect on them or a good effect? In general, vaccine should have no effect on them, but they should be fine. Hematological condition with the autoimmune reasons may get aggravated if the vaccine triggers the immune system responses. So you may have to provide support at that time. Carol says, why is mainstream media gaslighting India's recovery using ivermectin? Because it is against their, it does not serve their purpose of earning and scaring people. Mr. J says, thanks. So it can't adapt to the vaccine. That's the point. If it adapts to the vaccine, that means it has become so different that it is just now out of vaccine and natural infection. If there is a virus that has learned to either escape a natural infection or escape a vaccine, it has become a SARS-CoV-2 and it would go around the world again. Maybe it would not cause that much destruction now because the more vulnerable have already lost their life with this one, but it would still cause a lot of destruction. And it is very difficult for a vaccine or a naturally infected person to create these kind of variants. Folks who, it is funny that I say funny to make it light, not funny to make fun of it. I had asked a question in one of my videos a couple of weeks ago. I wanted to do a reverse week where I wanted to talk about all of these folks, Tenpennies and Geertz and Deltries and those folks, to kind of talk about where they are flawed. And in that process, I was talking about one of the persons, and I brought up Geertz's discussion as well. And I said, here is where he has issues and we should ask them these questions. And somebody actually went and asked them the questions. And for every question's answer, the person would say, Geert would say, well, tell them that this thing would outcompete that thing, which in science terms will mean I am saying so. This thing will outcompete that mechanism has to be proven. Without a proof, this is like if the lion is running after you, what would happen? Well, how fast is it running? And if you say it is going to run that fast that it would eat you, now what you're going to do? Well, nothing, now it's going to eat me. So similarly, if these folks would continue to say, well, this would be so bad that it would kill you. And then we say, no, it would not be. And they say, I told you it would kill you. Then they have to. So that is what happens with many of these concepts. Neil says, you would literally have to have everyone hooked up to producing some sort of real-time telemetry data like an F1 car does to really know through. Yes. Yeah, that's difficult. You can have a smaller number of people and then study them as a study, but still a difficult study to do. So Stephen says, when CDC recommends those that are not vaccinated should mask with vaccinated people who actually is in danger. CDC, I do not know how to explain CDC, because if they said it today, tomorrow they're going to change it back. So why should I explain them today to then have an about turn tomorrow? I have so far not taken an about turn because I've always stayed with the mechanisms. CDC is not on mechanisms. Carlos says, thank you for answering my question. You're very welcome. Genesis says, would like to get vaccine but seriously worry about clotting. So Genesis, the basic thing to see is, and I have been meaning to say it, so let me say it here first. J&J, Johnson & Johnson, 60 years and above, no, because their own paper, FDA briefing, says that it is lesser than 40% efficacious for 60 and above. Adenovirus-based vaccines, lesser than 50 women, no. Messenger RNA-based vaccines, lesser than 30 youngsters, no, considering the cardiac inflammation. What are the exclusions? So these are the exclusions that are in my mind. Are there any controllable situations here? This is not controllable until J&J changes their vaccine to become more efficacious for elderly, or not elderly, 60 and above, or they come back with 2-dose regime instead of 1 dose. Can this be changed? This can be changed either by looking at what causes this, or by creating a protocol for administration and managing the patient after the administration of the vaccine to see if they would develop the clot and how to fix it. Is this changeable? Not yet, because I have looked a lot about the mechanism explored here, and they do not have the mechanism. They simply say, yes, we know it is related, it is caused. Some papers are saying it is caused by the vaccine, some are saying related to the vaccine, but they still do not have the mechanism. That means we have to have a protocol for youngsters to take messenger RNA vaccines. Otherwise, it is dangerous for them. This is me not being an anti-vax. This is just simply what the data is showing. And ideally, all vaccination structures, administration structures, should look at this and say, hey guys, here is your algorithm, or the provider, your doctor, or the person who is going to give you the vaccine. In there, when you are standing in the line, there should be a desk here where you go, and the desk says, okay, what is your age? And remember that over here, we also say that anybody who has allergies cannot take this, right? So they say, okay, what is your age? What are your allergies status? What is your gender? And based on that, they say, okay, this vaccine or this, so you should not take this, you should not take this, you should take this. This is how they should quickly do this and say, okay, you're the safest vaccine for you is this, please go ahead. Too much to ask from health authorities. Rima says, Dr. Bean, did you see the Dr. Malone interview the chap claiming to be inventor of messenger RNA vaccine? No, I do not. Are they also saying something just like the person who invented RT-PCR? Somebody sent me an interview yesterday when I was traveling to come here to Oregon. That interview was this person, Deltry. I think he just brings in those who are fear mongers and who are conspiracy theorists, and he just brings in those. I was listening to that and thinking, wow, if I started bringing in those people, look how my brand would explode. So he had a person who was saying that I am an immunologist, my lifelong immunologist, and I do not know what else, cellular immunologist and the molecular immunologist. And with that, after telling those credentials, he kept making flawed conjectures. And it was funny for me to see both of them making incorrect assumptions and then saying to each other, yes, you're very correct. And then they were finding an agreement right away to be able to say, look, that person agreed, this is what can happen. So I don't know, Rima, is that the person? Rima, was that the video? There was a gentleman with a little gray beard and talking about I'm an immunologist. That was just so bizarre. Bizarre in a way that here is how I was actually thinking when I was listening to that I should sit down here with us and listen to them and identify where the faults were. For example, at one point, so let's say this is that gentleman with the gray beard who was the immunologist, career professional immunologist, and here is this guy who actually, I think he loves to have this kind of folks who are these conspiracy theorists, the Deltry guy. So he said at one point, I worry about autoimmune outcomes. And then he ended his sentence by saying, is that possible? Is that possible? And then this guy here, the big immunologist, said, see, I really like your last part of the sentence. Is that possible? And I was trained by the doctors who said, you should never say something is not possible. You should always say something is possible. So yes, that can be a possibility. So all of a sudden, in a weird way, they had agreed that this was the outcome. Fine, it is possible. But then there has to be some mechanism to give rise to that kind of a possibility, due to which we should think. We are doctors. We are not laymen to just think that will sky fall? Is that possible? Or will stars just land in my backyard? Is that possible? We are a doctor, so we should think like a doctor. So when we say, is autoimmune outcome of a vaccine possible? What is our basis for saying that? For example, can I say that the vaccine would train our immune system to create antibodies which will be directed against, for example, in the case of cardiac tissue inflammation in some youngsters, which would be directed against some part of the tissue, some tissue. And not only this would become a memory for our system, a fault in the B cells and the training system cells. So our immune system forever would now feel that our heart is an enemy and continue to attack that. That would be autoimmune. Some viruses actually trigger that. Most of the time autoimmunes are genetic, but some viruses can trigger it. So maybe this can be triggered, but at least explain some mechanism. So without mechanism, they were doing these kind of things. So that was just, I could actually detect, here is the fault, here is the fault, here is the bad concept he inserted, and now the rest of the house of cards is being built. So it is fun to actually hear them and then disassemble their house of cards, but it takes a lot of time to present these guys. Bobo says, Dr. Bean, is it a thing that vaccine may wipe out the natural immunity from natural infection? No. So this is Geertz. Now I can actually identify which concept comes from where. This is Geertz concept and no. And I actually, so this person who was trying to be go-between, she went and asked him this question that Mubin says it does not happen. And he responded and he said, tell him that this would outcompete this. Well, telling me this would outcompete that, where is the data? Where is any mechanism to show that this outcome competition occurs? Just by saying it would outcompete that. So if I say I'm going to race you and I will win, and you say, why do you say I'll win? I'll say, because I said I'll win. So now you have, other than racing me and seeing, you have no other way of proving that you will win. That is what outcompete means. So no, Bobo, that's not a mechanism. Christine says, autoimmune conditions are on the adverse events list of many vaccines. Again, the question, adverse events that happens because of the vaccine or the side effects that the vaccine think they can do, or actual autoimmune diseases caused by vaccine. And I'm not saying it cannot. You're seeing that in heart, the idiopathic thrombocytopenic purpura that occurred in the Florida doctors after Moderna was an autoimmune problem. Similarly, these cardiac inflammatory problems, as much as they continue to say that we do not know what it is, I think inside their heart as a doctor, they know that this is an antibody attacking that person's heart. That is an autoimmune disorder. So one can actually talk about those in a more concrete way, but making those sweeping, silly statements is also not right. And then combining those false statements to build something different is also, for example, this Canadian doctor who came in and said, well, we had some nurses who were willing to give us, I think the Japanese study, who were willing to let us see the antibody spike levels, and the spikes were accumulating in their ovaries. And then he said, this proves that people are in real danger. And so the question is, you actually took those blood from people who are working, and they were working, and you took their blood and they were fine. So even if they had the spike protein in their blood, they were fine, they were working. How are you now postulating that people are in danger? What happened to them? Are they in danger? Did they die? So there is just this weird separation of reality versus fear mongering. Andrew says, did you debunk the myocarditis being caused by the spike protein? I discussed that spike protein may not be the reason, but I discussed that the vaccine could trigger production of antibodies, which can then cause myocarditis, and that is possible. Some viruses do that. Vaccine can do that too, and they can't say no. Doug says, I'll outcompete Geared. So see, here is a statement. You will outcompete Geared. Somebody says, no, you cannot. And you say, no, I will outcompete him. What is the proof other than asking you both to run or whichever way you're going to outcompete him? So these are the kind of statements that just have no merit. Again, your statement has a merit. You would outcompete Geert. I'm with you. So Trudy says, is there any way to prevent or minimize activation, elevation of Epstein-Barr virus following a vaccine, Pfizer? Actually, EBV activation or elevation can be after any immune system disturbance. The basic thing to do should be that after the vaccine, you try to keep it under control by anti-inflammatories, or if needed, ivermectin-like things. The problem is that we haven't just made those protocols to help. I wish it would not take more than 2 or 3 days for the healthcare organizations to sit down and create these kind of protocols where they say things like these. This age, this gender, don't take this. This age, this gender, don't take that. This kind of a comorbidity, please, you cannot take any vaccine at all. Just take your chances with vitamin Ds and ivermectins and hydroxys and so on. It would not have taken a lot to do that, and it would have actually created confidence in people. People would have come in and said, as much as I'm scared of a vaccine, I feel that they have done their homework and they're giving me some choices and they are helping. So they must have thought something, and so I can trust them. At this time, there is no trust at all on both sides. So Jody says, was estimated that 2 out of a million may die from myocardial from offending vax. Extrapolated to millions of people around the world, expect a few hundred. And I think that it can be further helped by creating a protocol to say, how do you keep the antibodies from attacking the body? Again, if the autoimmune situation has occurred, then you cannot stop them. Whenever, let's say, you keep the person immunosuppressed, as soon as you would stop the immunosuppression, they would attack. So, but there should be some modulation. Glenn says, in Geert's latest video, he said, yes, vaccines appear to have worked, but people under the age of 16 should not be vaccinated. His hypotheses are falling apart. They were not even worthy of being hypotheses. He was actually peddling them as true mechanisms that he, being a maybe credentials of testing a lot on animals, he knew. And so he thought that the whole world should just listen to that. Look at the clinical outcome. When yesterday that Greg Beard person was talking with this Deltree guy, and they were talking about this mechanism and just winding each other up, and I was saying, don't you actually see the actual reality of both infection, not infection, and vaccine? You can find goods and bads in everything, but you can look at reality and know that, instead of sitting here and postulating in front of people, and people have no way of knowing what is right and what is wrong, the way you are confusing them or conflating them. I was able to quickly separate them because I've been studying this my whole life. Alfred Chow says, arm wrestle geared. Yep. Cool Beans should have a challenge for arm wrestling for all these 10 pennies and Dolores type people. Okay, so I think we are at the end of the questions. Maximus says, do you protect against fomite transmission at all, like wipe down groceries, packages? So I used to do a lot of that. So I used to have a spray. So I would spray everything, and then plus I used to wear hand gloves. The behavioral bad behaviors that have crept in me is one of those, is that stopped using hand gloves after vaccination. This does not mean I'm protected. This also does not mean vaccines are not efficacious. This simply means psychologically I have kind of changed a little from a vaccine, which may be an error, which may be a mistake. Correct. So there was one more question. Liza, hey Liza, how are you? Seen you after a long time. It makes sense that after COVID, influenza hits harder and with more complications. So the answer will be, if COVID has caused the person's immune system and the respiratory system to be vulnerable, then any other infection, especially respiratory infection, can beat them down. But if they have recovered, they are not weak, their immune system is fine, their diabetes is not, their hypertension is not, their respiratory epithelium is fine, then they would not, it would be the same as others, as without COVID. So ET says, when are you planning to relax about COVID? That's a good question. I think this confidence would develop slowly. For example, when I came here yesterday, my colleague, she is fully vaccinated because she's a healthcare worker. And so she said, I don't need a mask, but I kept wearing a mask for some time. Then I felt so odd that I was the only one wearing a mask. So I think that psychological thing would slowly go away. And everybody is going to respond differently. And I'm sorry for the camera shake. You're very welcome. So let's do this. Let's stop for today. Please do me a favor. Please like, subscribe, and share. And if you would like to support this work, there are 3 links. One is to buy me a coffee. The other one is to use PayPal to support this work. And the third one is to be a patron. Thank you very much. And I would see you with the same background and the same haircut tomorrow as well. If in this whole process there is some gap, please tell me in the comments so I can fix it. The audio, I don't have the cover around the mic, so there may be an echo from the room. just tell me what you felt different, and if it needs to be fixed, so I can do it. So thank you very much. Have a good day. I'll see you tomorrow.